Hi, I'm Wendy Bird, President of EMDRIA, and I'm here today to present the EMDRIA 2022 Francine Shapiro Award to Dr. Deborah Korn. Dr. Korn is a licensed clinical psychologist, and she maintains a private practice in Cambridge, Massachusetts. She's an adjunct training faculty member at the Vessel van der Kolk's Trauma Research Foundation in Boston. She has been on the faculty of the EMDR Institute for the past 29 years and is the former clinical director of the women's trauma programs at Charter Brookside and Charles River Hospitals. She is a past board member of the New England Society for the Treatment of Trauma and Dissociation. Dr. Korn has authored or co-authored numerous articles and chapters focused on EMDR therapy, including comprehensive reviews of EMDR applications with complex PTSD. She is an EMDR International Association approved consultant and is also on the editorial board of the Journal of EMDR Practice and Research. She has been a keynote speaker at EMDRIA, at the EMDR Europe and EMDR Iberoamerica conferences, and was invited to present EMDRIA's very first Master Series class in 2003. She recently served as the vice chair of the Clinical Practice Group and on the steering committee of the Council of Scholars, an international group associated with the Future of EMDR Therapy project. Dr. Korn also presents and consults internationally on the treatment of adult survivors of childhood abuse and neglect. And she is the co-author of Every Memory Deserves Respect, a 2021 book about trauma, recovery, and EMDR therapy written for the layperson. As a clinician, teacher, researcher, and consultant, Dr. Korn is known for her EMDR expertise, as well as her creative integration of many different clinical models. When she's not hard at work, you'll likely find her biking, hiking, singing, and kicking up her heels with family and friends. And I'd like to invite you on into a Zoom conversation that I recently had with Dr. Deborah Korn. And I'd like to go back to the beginning of your EMDR experience. What was your introduction and initiation into EMDR and conceptualizing trauma treatment?
Well, over 30 years ago, in the summer of 1991, I traveled to Denver, Colorado to visit my graduate school mentor, Andy Sweet. I had graduated with a doctorate from the University of Denver School of Professional Psychology in 1989, and Andy had basically taught me everything I knew about working with trauma survivors. And I was telling him how frustrated I was feeling with the limitations of the treatment models available to me when treating chronic trauma survivors. Teaching patients with a raft of cognitive behavioral coping skills and helping them to manage their symptoms seemed necessary, but not sufficient. They were typically able to achieve some degree of short-term relief, but a cure for their complicated symptoms and deep distress seemed elusive to them and to me. Memories associated with fear and shame and helplessness would continue to get reactivated, requiring ongoing efforts at top-down cognitive self-management. And more traditional talk therapy models lack the focus and the clear path to healing that I was looking for. I was discouraged by the idea put forth in many of these models that treatment needed to be long-term, sometimes very long-term, to be effective. And most of my clients could not tolerate flooding, an early form of prolonged exposure. I was looking for something that paid more attention to the body, to the ways that trauma remains locked in the nervous system. And as we sat in Andy's backyard eating lunch, he said to me, "Debbie, you need to listen to me. There's this new therapy called EMDR, and it's something quite unique. It looks and sounds kind of wacky, but I am getting really remarkable results with it. And you must go and get trained, and you have to run. Do not walk, but run." So I ran and I got trained with Francine Shapiro later that year. And at the time of my basic EMDR training, I was the clinical director of an inpatient psychiatric unit specializing in the treatment of women recovering from both acute and chronic trauma. I was treating women struggling with severe suicidal ideation and self-injury, eating disorders, addictions. Many of them had made very serious suicide attempts. And I used EMDR every single day, starting the day after I completed my basic training on this inpatient unit. And my patients were truly my earliest teachers and collaborators. And I quickly learned how to adapt Francine Shapiro's basic protocol when working with individuals who had endured prolonged and repeated trauma, particularly those who had experienced significant childhood abuse and neglect. And I had the honor of becoming a faculty member at the EMDR Institute, Francine Shapiro's Training Institute, in 1993, and started teaching about EMDR here in the US and other parts of the world, particularly with regard to applications with complex PTSD and dissociative disorders. And I was intensely drawn to EMDR because I wanted something that was effective and efficient, collaborative and tolerable for my clients. I wanted something that was dependable and precise. I wanted something that didn't necessarily require patients to recount all of the details of their traumatic experiences. And I loved that EMDR integrated both top-down and bottom-up work and attended to emotions, the body, and people's belief systems. I found it to be deeply integrative and experiential, and it seemed to help people in profound ways to come to terms with their past, their present, and their futures. And it helped people with developmental repair and unfinished business and move them toward post-traumatic growth and greater resilience. But I'd say mostly, though, I was drawn to EMDR because it seemed to work better and faster than anything I had used previously. And as a bonus, I found the work to be meaningfully intimate and fascinating and rewarding.
Yeah, I mean, I can imagine what a paradigm shift EMDR was at that time, and how enthusiastic and it would feel to be at that early cutting edge of doing that work. You mentioned that you quickly adapted the basic protocol for working with people who have had endured prolonged trauma and repeated trauma. I wonder if you could say a little bit more about that and about the beginnings of RDI.
Yes. I simply learned in those early days that certain clients, those with higher levels of dysregulation and dissociation, required more preparation and resourcing, more active interweaves, greater attention to co-regulation, more EMD, and more titration with less pursuit of associations. My early experiences on the inpatient unit actually inspired my collaboration with Andrew Leeds in developing the resource development and installation protocol, RDI.
So grateful that it did. Something that we use all the time and is such a great, valuable resource for EMDR.
Thank you.
Yeah.
Yeah, Debbie, as you reflect on those early days and where mental health and EMDR are today, what do you see as the pivotal events or stages of development in that progression?
Well, you know, we can talk about EMDR's developmental history through two different lenses. With one lens, we can look at its development in terms of research and receptivity within the academic community. And with another, we can look at EMDR's developmental trajectory in terms of clinical advancements. In the early days, before we had much solid research to back up our clinical claims, Francine had to endure a ridiculous amount of criticism and disrespect. Her battle cry was research, research, research. She recognized the importance of research if we were going to move forward. I think it took much longer than she had hoped for early research studies to get designed, implemented, and published. And even as the number of RCTs increased, the quality of the research continued to come under scrutiny. And I think that we hit a turning point in terms of our place in the larger academic clinical traumatic stress world once there were some gold standard research studies that we could cite. I was one of the co-authors of the 2007 study looking at EMDR versus fluoxetine, Prozac, in the treatment of PTSD. Bessel van der Kolk was the primary investigator. We were very deliberate in adhering to those gold standard guidelines, and we worked with some very complex cases and published some pretty impressive results, if I do say so myself, in support of EMDR's effectiveness with both adult and childhood trauma survivors with PTSD. That was an incredible learning experience and privilege. Eventually, with the publication of more and more well-done research studies, EMDR started to get recognized and recommended in the treatment guidelines of key organizations around the world World Health Organization, the Departments of Defense and Veterans Affairs, the American Psychiatric Association. I think that recognition served as another turning point. And today there is little to no controversy about EMDR's effectiveness for PTSD. And in comparison studies, its outcomes are comparable to other evidence-based treatments. In terms of EMDR's clinical development, there's the evolution from a simple technique to a comprehensive psychotherapy, the move from EMD to EMDR to EMDR therapy. And we've transitioned from thinking about EMDR as a treatment for PTSD and recognized trauma-related disorders to thinking about EMDR as a psychotherapy that addresses the impact of adverse experiences, both big and little t, abuse and neglect, acts of omission and acts of commission. All of us use EMDR to address developmental trauma and long-standing attachment-based issues, targeting early learning experience, what happened, and also what didn't happen. We understand that EMDR is not just about symptom reduction, but also about self-development, building resilience, and setting goals for the future. And it has grown as a comprehensive psychotherapy used to treat complex whole humans, not just symptoms. We've continued to incorporate theoretical research and clinical advances from affective neuroscience, interpersonal neurobiology, body-oriented therapies, the field of ego state and dissociative disorder treatment, and the field of attachment studies.
Being an early implementer of EMDR therapy, I can imagine, I mean, that was just such a beautiful, comprehensive overview of the advancements of EMDR. But I'd love to hear just in your own personal practice, some pivotal moments for you over the course of your career in terms of your use of EMDR therapy and where you come from and where we are now.
Mm-hmm. Well, I would say that in my own practice, I continued to be amazed over the course of time about the breadth of applications where I would see success with EMDR. You know, I began my work with complex trauma survivors, dissociative disorders, including DID. And later in my practice, I moved into doing more work with folks involved with the medical system, working closely with some of the hospitals in the Boston area, and treated cancer survivors, treated folks undergoing serious surgeries, folks experiencing phobias related to medical procedures, and really found that EMDR was incredible in helping people to prepare for these life-threatening illnesses that were wreaking havoc in their lives. I also, explored using EMDR with couples and with families for a period of time, and was amazed at how profound the impact could be when working within a system with EMDR. And I think that as I have explored different populations over the course of time, as hard as it is to believe, my confidence in EMDR has continued to grow. I mean, I'd say I developed a real confidence in EMDR therapy early on because I was working in such an intensive environment, working in an inpatient setting, working in partial hospitalization settings. But as I branched out and used EMDR across populations and with different kinds of problems, I just developed more and more awe and respect and confidence.
I think that's a common thing that you hear among EMDR clinicians. And I love that you brought in, I haven't found many, especially evidence-based theories out there that don't fit into the AIP model and EMDR. And so it's really just kind of validating to go, yeah, that makes sense. And here's how we look at it through.
Yeah. Absolutely.
Lens. Yeah. Switching gears a little bit, I wonder with where you are today with all your interactions with so many after your publication of your book, Where Every Memory Deserves Respect. What do you see as the future trajectory of EMDR and trauma treatment overall?
Mm-hmm. Well, my book has been out for about a year and a half, and since its release, I've had so many remarkable opportunities to speak with different communities and special interest groups I've spoken to or spoken with veterans, doctors and nurses, depression and bipolar support groups, teachers, prisoners, recovering addicts, parenting groups, and people dealing with schizophrenia, people dealing with the murder of family members and grief related to all kinds of losses. And coming out of the pandemic, it's clear to me that we are in a mental health crisis and that people are desperate for relief and hope. Recent statistics certainly support this perception. In recent years, we have endured so much, and individuals in BIPOC communities and marginalized and oppressed communities have suffered disproportionately. The need for trauma treatment in EMDR is greater than ever. In my opinion, over the past 30 plus years, we have done a great job of pursuing research and honing our craft, offering better and better services to our clients. But we have failed, I think, to really, really get the word out about EMDR therapy. People have a sense of talk-oriented psychotherapy. They know what CBT is. However, so many people who are suffering have never heard about EMDR and do not believe that they can get better. And even though there is so much more trauma awareness and education available since the start of the pandemic, so many people still remain afraid or embarrassed to ask for help. There's also considerable misinformation out there about EMDR. We need to work to get the word out. I consider this a call to action, perhaps. We also need to get more therapists trained in EMDR psychotherapy, specific EMDR therapy protocols, and EMDR-derived techniques. We need to continue to explore ways to scale up and reach more people with greater efficiency. I would also love to see more cross-pollination conversations between curious, dedicated therapists trained in different models, collaborative projects rather than competitions, and conversations across different disciplines.
Yes, I think that's very well put. Very well put.
Debbie, of course, EMDR has had a challenging path at times. What qualities do you think have caused both treatment and the clinicians to persevere, continue forward, and even thrive despite early developmental challenges?
I think we are holding an incredible product in our hands and our hearts. As I said earlier, EMDR is efficient, effective, it's affordable, it's adaptable. It can be used immediately after a trauma. It can be used cross-culturally with adaptations. It can be used years after a traumatic experience, even if someone consciously remembers very little about that experience. It has applicability across the DSM or the ICD-11. It can be used in groups and with very young children or elderly clients with dementia. It doesn't require homework or extensive cognitive abilities. It can be done with very minimal access to language. EMDR is useful in treating disorders that are often labeled as hard to treat. Addictions, work with sexual offenders, psychotic disorders, personality disorders, and complex traumatic stress disorders, including DID. It's useful in medical settings and prison settings and school environments. And Francine Shapiro was fierce and determined and brilliant and an integrationist. She always believed that we should continue to evolve our procedures and our protocols, and that we should find ways to incorporate effective strategies from other treatment paradigms. You'll remember that she edited a brilliant book in 2002, EMDR is an integrative psychotherapy approach. Experts of diverse orientations explore the paradigm prism. Beautiful name. I think that EMDR trained clinicians have persevered and continued to champion this therapy because they have seen how effective it is, and they have felt the satisfaction that comes from doing deeply meaningful work. We all want to make a difference, and we all want to be able to say to our clients, I know that you're suffering, but you can and will get better. I can help you, and it's not going to take a lifetime. And lastly, we have a beautiful, vibrant community of EMDR therapists committed to supporting one another and growing together. We've enjoyed learning together and playing together over all of these years.
I love that. And I know that's for so many of us clinicians, we feel very indebted and grateful to all the work that came before that helped us continue to move forward and to advance the cause of EMDR therapy. When you think about right now, you're standing at the pinnacle of your professional contributions. What do you see as being next for you?
Well, now that my youngest is off to college, I'm looking forward to doing more teaching and maybe some more writing. I'm looking for ways to combine my commitment to social justice with my love of EMDR. There are a number of opportunities that I'm exploring right now that will allow me to continue my mental health advocacy work. And I'm particularly interested in working with underserved, under-resourced communities. I'm also really passionate about training our next generation of EMDR therapists. I love mentoring newly trained early career EMDR therapists, especially those who are interested in working with complex trauma survivors and those with dissociative disorders. I'm really looking forward to spending more time goofing around with my husband now that we're empty nesters. So I think there's still a lot ahead for me, and I'm excited to see how it unfolds.
That's great, Deb. That sounds like a wonderful future ahead of you.
Yes. So I am so honored to present the Francine Shapiro Award. So, I mean, you have clearly shown why you are so deserving of this award. Here I have the EMDRIA 2022 Francine Shapiro Award, and it is my honor to thank you for all that you have done and wish you even greater impact in the future. And on behalf of the EMDRIA board and the organization, this is our highest honor that can be bestowed by EMDRIA. And so I'm going to pass this award over to you.
Thank you so much, Wendy.
You are so welcome. Thank you for all that you have done to contribute to EMDR now and in the future.
Thank you very, very much.
Thank you so much, Debbie.